years, he told me, from 1959 to 1993 at the NIH, involved in cardiovascular research, and is extensively published in the area of cardiovascular pathology. He is now a director of the Baylor Cardiovascular Institute, and we're welcoming him back to Texas in that capacity. He is also serving in the capacity and doing an excellent job, in my opinion, as the editor-in-chief of the American Journal of Cardiology, which I think has improved its content considerably since he's taken the helm as editor. It's a great privilege and pleasure to welcome Dr. Roberts.
Well, thank you very much, Dr. Gambenthala. It's a treat to be here. I went to SMU to college, and so I was away a long time. So it's really a treat to be back here in Texas. I was here for a football game in the 50s, so it's changed a bit down here since then. Go ahead with the first slide, if you would. What I'm going to talk about is atherosclerosis, hopefully how to prevent it, and if we have too much of it, what we can do about it. Now, what we're looking at here is a coronary artery, and this is a coronary artery that is terribly narrowed, of course. The lumen margin should be all the way out here, but if you just look at that person next to you, one of you are going to die from coronary arteries or other arteries which look like this. Now, I know it's the other one, not you, but nearly 50% of us in this country are going to cross the river, so to speak, because of consequences of atherosclerosis. And the sad thing is that atherosclerosis is unequivocally genetic in origin in 1 out of 500 people. 1 out of 500. The rest of us, we determine for practical purposes whether or not we are going to get sufficient atherosclerotic plaques in our arteries to cause problems. Now, what I would like to do here is to try, that needs focusing, I think. Oh, I can do that. Maybe I can't. Is to try to answer these 6 questions. Question 1, how much atherosclerosis is needed in the coronary arteries to cause myocardial ischemia? How much plaque do you have to have there? Well, let's look at acute myocardial infarction. Now, this is the amount of narrowing in patients with fatal acute myocardial infarction. My own view is that there is not much difference in the quantity of plaque in patients with symptomatic and fatal myocardial ischemia. I won't go into the reasons, but I think there is evidence to point out that there's not much different. If we look at the 4 major arteries in the typical patient with acute myocardial infarction, the right coronary artery is generally about 10 centimeters, the left main is about 1, the left anterior descending is about 10, left circumflex is about 6. That's 27 centimeters total. Now, if we divide each centimeter into 2 little 5-millimeter segments, we come up with 54 or 55 per patient. Now, if we take a histologic section through the center of each of those 5-millimeter segments and ask how much narrowing is present, it turns out, and this is cross-sectional area narrowing, not diameter reduction, the units of angiography. This is cross-sectional area narrowing. If we take the circle and divide it into 4 quadrants, over 3 of those quadrants are obliterated in 1/3 of the lengths of these arteries, 1/3. Then another 1/3, about 51 to 75% narrowed, and only about 5% of the segments even approach normal, and it's extremely uncommon to see a normal one among these patients. Now, the point of all this is that the quantity of plaque is huge, and unless there's an enormous quantity of plaque, we don't get in trouble. This is a montage of coronary artery segments in a single patient. This patient had unstable angina. Now, each one of these photomicrographs represents a single cross-section through that little bitty 5mm segment. Now, try to go down this artery and find one that even approaches normal. This is the left main, these two segments. Terribly narrowed here. Look at that left anterior descending. Now, if you're going to do an angioplasty here, where would you blow up the balloon? Here, 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 here. Look at it. Here, 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 here. You get over here, it's pretty good. That little fellow's pretty good right there. Left circumflex happens to be the dominant artery here. Look at this, all the way out, terribly narrow. Now, that's what the patient, and that's what you're up against in somebody with symptomatic myocardial ischemia. And this is not hereditary in 499 out of 500 of us. If we look at that another way and just ask, how big is the lumen, the inside of the four major arteries, left main, left anterior descending, left circumflex, and right, and what percent of that is filled up with plaque in patients with fatal coronary disease? The answer is about 67%. Controls that we used about half of that. So the bad news is that, or the good news in actuality, is that you have to have an awful lot of it or we don't get in trouble. The bad news is that despite the fact we have to have an awful lot of it, many of us acquire a sufficient amount so that we do get in trouble. Question 2, what do the atherosclerotic plaques consist of? Anybody?
Cholesterol, fibrin.
Cholesterol, fibrin, platelets, calcium, foam cells. Well, actually, until about 3 or 4 years ago, there was no quantitative information on the composition of atherosclerotic plaques. And today, of course, we're in this era of reversibility of plaques, or potential reversibility, of what portions of the plaques can disappear. Well, now what was done here, we took a group of patients all over 40 years of age with fatal coronary disease of varying types. And we took these 5mm sections and hooked them up to a computer setup. And this computer setup would read out the percent of the plaques consisting of these various components. And we divided the plaques into those that caused minimal luminal narrowing, 25% or less, to those that caused virtual total occlusion of the artery. Now, the answer to the question that the dominant component of atherosclerotic plaques is not cholesterol, it's not lipid, it's not platelets, it's not fibrin, it's scar tissue, fibrous tissue. Now, the yellow represents dense or acellular fibrous tissue, and the red represents cellular fibrous tissue, and that makes up overall about 75% of the plaque. And then the calcium, which is in blue here, represents approximately 10%, a little less. The pultaceous debris, I like that phrase, but that means extracellular lipid. Now, this is clearly reversible, at least experimentally. If you take high cholesterol and drop it, this extracellular lipid can be sucked out of there. But you might notice that extracellular lipid is present only in the big plaques. It's not present in the little plaques. And then foam cells are relatively infrequent in these patients over 40 years of age. So what portion of this plaque is reversible? Is the green, maybe some of this white, and there's some experimental evidence that maybe some of this cellular fibrous tissue is a bit reversible. Now, if you look at, these are in patients with fatal coronary disease. If you look in patients who are 10 years of age, or 15, or 20, I think the quantity of lipid in them is higher. So the answer to the question, what do these plaques consist of? in patients with fatal coronary disease, the answer is predominantly fibrous tissue, scar tissue. When you cut your arm, it heals by a scar. The same thing in these plaques. Question 3, how many direct atherosclerotic risk factors exist? Now, what's the key word in that question? Direct. Now, each of us would probably define that differently. Now, I would define that as a risk factor that you have to have in order to get atherosclerosis. Now, if you define it that way, how many risk factors are there? 10? 5? 3? 1? What do you say? 1. Anybody else? Everybody agree it's 1? What? You don't agree. How many?
5.
5. Okay. And they are what?
Smoking.
Smoking. So if you're not a smoker, you don't get it.
No, it's
Oh,
I didn't say 1. I know you said that.
I know you didn't. But you said 5. Smoking. And you define direct the same way that I do, that you have to have it in order to get atherosclerosis?
No.
Oh, how do you define it?
Define, I'm sorry, I didn't understand what you said. Define what?
Okay, the question is, how many direct atherosclerotic risk factors are there? Now, I said that I define the word direct, meaning you had to have it or you don't get atherosclerosis.
Okay, well, with that definition, the only absolute risk factor may be the lipids.
Okay. Well, we're communicating then. I agree with you. There are not many diseases that have a multifactorial origin. And in my view, there's only, if somebody asked me, doctor, what causes atherosclerosis, I would say cholesterol. Now, what is elevated? In my view, in order to make sure you don't get atherosclerosis of any significance, that level has to be under 150 milligrams per deciliter. Well, you can argue, well, none of my patients have levels of that. But when we're born, our umbilical blood apparently has a total cholesterol of 75 milligrams per deciliter. Within 2 weeks of life, on average, it shoots up to about 150, and then it stays about 150 until we graduate from high school, and then it gradually starts going up. Only 5% of the population after age 40 have a total cholesterol in this area. But if we want to make sure we're going to not have sufficient plaque to cause trouble, that's the number we should shoot for. Now, that does not mean, of course, that these other things are not important. High blood pressure, we have 60 million Americans with high blood pressure. If you want to prevent stroke, if you want to prevent aortic dissection, you've got to get that blood pressure to roughly normal levels. You can't be healthy, in my view, and smoke cigarettes, but this is not a direct atherosclerotic risk factor. If the cholesterol level is over 150, these things are indeed accelerators, but they're not independent factors, in my view. Now, what factors indicate that cholesterol causes atherosclerosis? How many factors would clearly convince a jury that this is a cholesterol problem? Well, in my view, there's 6 factors. One is this started way back with the Russians in about 1908, and they fed high cholesterol diets to certain non-human animals. Which ones did they choose? Pigs. What? Pigs. What? Rabbits. That's correct. That's what they picked, were rabbits. You can produce atherosclerosis only in an herbivore. You can give a dog or cat a carnivore, all the fat, all the cholesterol you want, but you can't produce an atherosclerotic plaque. Now, can you give a human being all the fat and all the cholesterol they may want? Can you produce an atherosclerotic plaque?
Yeah.
So what does that say about human beings? Okay. And did you enjoy your chicken? Huh?
It was good.
It was good, okay. Okay, so there were rabbits. The second thing was found was that the biochemists came in and they ground up these plaques and they found cholesterol within them. And then not much happened until after World War II, when Ansel Keys, whom I consider a great man, he's 91 I think now, he's living on the French Riviera, he's still a healthy gentleman I believe. He led this group in the so-called 7 Nation studies, where they went to various countries around the world and found atherosclerosis in some populations and not in others. And I conclude from these studies this statement: atherosclerotic plaques large enough to produce clinical problems occur only in people having serum total cholesterol levels greater than 150 milligrams per deciliter. Now, items 4, 5, and 6 have really been solidified the last decade. And that is, the higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the plaques in the arteries. Number 5 came in 1984 and 1987. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. And 5 of the 13 studies in 6 were published in 1990, and about 5 others since then. Atherosclerotic plaques regress, or at least they have that potential, when high cholesterol levels are lowered. So in my view, the items lining up supporting the cholesterol thesis are quite strong. Now, this slide came from the Lipid Research Clinic. It has to do with what percent of the U.S. population have total cholesterol levels greater than 240 milligrams per deciliter. Now, 240 is a very high number. It turns out that from ages 20 to 74, about 25% of that population in this country have total cholesterol levels greater than 240. But look at this, ladies. After age 55, this is a total here, about half the women in this country have total cholesterol levels greater than 240. Now, men have higher levels, or at least a higher percent have these very high levels earlier in life. Women have a higher percent later in life. The reason, I think, one of the reasons that men have a lower frequency of these high levels is that those with higher levels earlier in life are no longer with us. But the point of all this is that elevated cholesterol level is really a major problem in this nation. This is Ansel Keys' famous 7 Nation study. He went to these nations, found the frequency of coronary disease very low in some populations, very high in other populations. And we take the lowest and the highest nation, Japan. This was work done in the 1960s. Japan total cholesterol averaged about 150, and in Finland it was approaching 300. This study has always appealed to me. It's from Stamler, published in 1986. And Stamler and his group screened over 350,000 men. They were all asymptomatic, sorry ladies, aged 35 to 57. And they did histories and so on, and various cholesterol levels, or at least the total cholesterol, and they divided the patients into 10 groups according to their serum total cholesterol level. And what we see as that level goes up, 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 the coronary artery mortality, and this is a 6-year mortality here, at 10 years, and at 12 years it's much higher. That level goes up, up, up. No study, in my view, shows any better that total cholesterol is a quantity. The higher that number, the greater the risk. Now this is a slide which was made from putting together two primary prevention trials, the Lipid Research Clinic study and the Helsinki Heart Study. Each of these two studies studied approximately 4,000 men, average age of 47 or 48. None of these people had an atherosclerotic event before they went on the study. And in one of the studies, it took 5 years to achieve significance. The other one, it took 7 years. But what both of those studies show was this. If you lower somebody's total cholesterol by 10%, let's say from 200 to 180, you decrease the chances of a heart attack by 30%. In other words, for every 1% reduction in total cholesterol, there is a 3% reduction in the chance of having a heart attack. Unfortunately, it also goes in reverse. If you raise total cholesterol by 10%, the chance of a heart attack goes up by 30%. So it works both ways, unfortunately. Now, the secondary prevention trials have really come into their own primarily this decade. Now, secondary prevention, of course, means that one is studying a group of people who have already had a heart attack, or they've had a peripheral vascular event, or they have carotid arterial stenosis. And then half of the group are put on a cholesterol-lowering regime. It may be a pure vegetarian diet with 6% of calories from fat or 10% of calories from fat. It may be a lower fat cholesterol diet plus one or more lipid-lowering drugs. It may be a partial ileal bypass operation, which also lowers total cholesterol about 23%. Whatever it is, when the groups of patients in the treatment group were compared to the control group, regression, this is by angiogram, occurred in a much higher frequency in the treatment group than in the non-treatment group. And even more important, in my view, is that evidence of progression, that is, the plaques getting bigger and the lumens getting smaller, was very much higher in the non-treatment group compared to the treatment group. Now, what does this mean? To me, what this means is that people who've had an atherosclerotic event, of course they should be on a cholesterol and fat low diet, but in my view, at least early on, they clearly should be on a lipid-lowering drug, one or more, because what the objective is to get that cholesterol level as low as possible, as quick as possible. And I don't think that's possible or worth the delay in somebody who's already had a heart attack. So if I had a heart attack, I would want to be on one or more cholesterol-lowering drugs. If I had angioplasty, I would. If I had bypass operation, I would. I guarantee you. Now, how does it work? Whether the fibrous tissue of a plaque is really reversible remains to be proven, in my view. Experimentally, there's no question the lipid component is reversible. So if we can get that lipid down from this size to this size, it may be possible to open up that lumen a bit so that it is less than 75% narrowed rather than over 75% narrowed. And theoretically, at least, the physiologists say that unless an artery, a pipe, or tube is narrowed over 75%, that there's no diminution in flow through the tube or pipe. So if we could get it under 75%, we're home free. Furthermore, plaques can be arrested. No new plaques can form if we get that cholesterol level down to the 150 arena. Question 5, how can symptomatic atherosclerosis be prevented? And if present, how can it be arrested? Anybody?
Reverse risk factors.
Reverse risk factors, but what's your objective?
Lower cholesterol.
Lower cholesterol. So if the cholesterol is normal, our challenge is to keep it from going up. If it is up, our challenge is to bring it down to these, what I would call normal levels. Question 6, how can normal cholesterol levels be prevented from rising, and how can elevated levels be lowered to normal? Now, that's our major health challenge in the USA today, in my view. How can we do that? Well, first of all, we must decrease the quantity of cholesterol each of us take in every day. Number 2, we must decrease the quantity of fat we take in every day, and particularly saturated fat. And 3, we must decrease the total calories that we take in every day. Now, none of these are particularly easy, of course. Now, this is a slide which shows studies from 3 different groups of investigators. And what they did was increase the quantity of cholesterol fed to these individuals. And when they did that, they saw that the cholesterol levels in the blood goes up. Now, that doesn't work perfectly in each one of us. Some of us can indeed eat 2 or 3 eggs, and our cholesterol level won't change much. Others of us can eat 3 eggs, and it will shoot up. So each of us have a different response to cholesterol-lowering and fat-lowering diets. Some people are very sensitive to these diets, and their levels change quite a bit, and others are not nearly as sensitive. Now, we hear a lot of talk about, well, we've got to switch from eating cows, and we got to eat more chickens, turkeys, and fish. Well, we shouldn't switch from one flesh to another thinking we're going to get less cholesterol, because the amount of cholesterol in 100 grams of any of these fleshes are the same. The thing that's good about fish, of course, is that it's relatively low in fat, very low in, extremely low in some of the fish, whereas there's fat in most of the others. As a matter of fact, I don't worry too much about cholesterol. Cholesterol, as you know, comes from animals and their products. So if we don't eat animals and their products, we don't take in any cholesterol. We take in about 500 milligrams of cholesterol every day. Now, how do you picture 500 milligrams? It's so small, it hardly gives us a calorie. I can tell you that a toothpick weighs 100 milligrams. So most of us take in the equivalent of 5 toothpicks of cholesterol every day. And about half of that comes from the visible and non-visible eggs we eat. And another major portion comes from eating cows. If we give up those 2 elements, we're going to give up most of the cholesterol. Now, fat, on the other hand, is a major problem. In the U.S., most of us take in over 100 grams of fat every day. Many of us take in over 150 grams of fat a day. I saw an average recently of 140 grams of fat per adult American. Now, I can tell you that a deck of cards weighs 75 grams. And none of us should be taking in over 75 grams or a deck of cards of fat every day. Probably men should take in no more than 60, and probably women should take in no more than 50 grams of fat every day. The problem with fat is that, let's say we take in 120 grams. About a third of it is saturated. So if we take in 120 grams of fat, it means we take in about 40 grams of saturated fat. And when that saturated fat enters our bodies, it's essentially converted into cholesterol. So our biggest source of cholesterol is not the direct stuff we bring in, but that which comes in through the saturated fat channel. Now, if you want to get a good, high, heavy dose of fat, a good grease job quickly, there's no better place to go, of course, in the fast food industry. it always interests me that around every campus they're just loaded with these fast food chains, and I noticed a few here in riding in. Michael Jacobson and Sarah Fritchner went around to the top 15 fast food chains in this nation and tried to determine the ingredients of the foods. And here are the ingredients of the hamburgers. Carl's Jr. Double Western Bacon Cheeseburger, folks, and also a Jack in the Box Ultimate Cheeseburger. These are the coronary artery bypass specials. It used to be the Burger King, well, the Burger King is still high. The Burger King double beef Whopper with cheese. We're talking about 1,000 calories in each of these hamburgers. And if you take those suckers and squeeze them real hard, you can come up with about 15 teaspoons of fat, much of which is saturated in that single hamburger. Now, the daily values recommended for sodium every day, this is not salt, not sodium chloride, but sodium alone, is 2,400 milligrams, which is probably too much. But you can almost get that in one of these hamburgers sometimes. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? That needs focusing. If most of these slides need focusing. This fellow John Love wrote an interesting book. He entitled it McDonald's Behind the Arches. Bill Castelli talks on this subject some, and he's a fellow who heads the Framingham program, and he calls the arches of McDonald's the entrances into the pearly gates, and I think he is right. Look at this one. Slightly more than 50% of the population of the USA lives within 3 minutes of a McDonald's. McDonald's is the biggest purchaser or killer of cows in the country, whatever your perspective is. Since they started Chicken McNuggets, they're the biggest purchaser, second biggest purchaser or killer of chickens. McDonald's has served, this is an old slide, over 90 billion hamburgers alone. And think how many atherosclerotic plaques. I like this number 7. McDonald's has employed at one time or another over 8 million workers. 7% of the entire U.S. workforce in McDonald's has replaced the U.S. Army as America's largest job training organization. This is power. They're the biggest, world's largest owner of commercial real estate. There's a book that came out a few years ago entitled In One Day. And the author asks the question, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food are consumed every day, roughly 200 billion more than we need. Now, those 200 billion excess would feed the entire country of Mexico every day, no problem. In 1990, folks, we reached in this country 60%. 3 out of every 5 adults in the USA are overweight. 3 out of every 5. When I was at NIH, look around. When I was at NIH, we had a lot of foreign visitors, and I would always ask them, what strikes you most about America and Americans? And the most, well, of course, that produced a lot of different answers, but the most common answer was how many fat people we have in the USA. No nation in the history has had the excess calories that we have in our population. Nearly 100,000 cattle are slaughtered every day, yielding 60 million pounds of red meat. As you know, we have 260 million people in this country and 100 million cows, and we slaughter 100,000 of them every day. It's not an easy thing to talk about in Texas here, but as you know, in the USA and Canada, we do it differently than in the rest of the world. We bring these cows into these feedlots their last 6 months or so of life, and there feed them 20, 25 pounds of grain and soybean every day. And then why do we do that? We do that, of course, to make them fat. And why do we want them to be fat? Because they taste better. And then we kill them, and then they kill us. And that's the way it works. Now, In addition, we kill about 250,000 hogs every day and eat 4 million pounds of bacon. Bacon is really the pits. It's 85% of fat, I think. If you don't know what it is, make a hot dog out of it. And we eat about 47 million of them every day. McDonald's puts 2,500 cows on their tables every day. Dairy cows yield 47 million gallons of milk in the USA every day. We eat 170 million eggs every day in the USA. And folks, if you're a chicken, don't wander into the USA. We kill about 12 million chickens every day in the USA. We also eat about 50 million pounds of sugar every day, an average of 21 teaspoons apiece. Can you imagine waking up every morning, looking at the bedside table, and seeing 21 teaspoons of sugar there? These processed foods we all eat are loaded with sugar, and they're loaded with salt. We also eat a lot of ice cream and about 10 million pounds of candy every day. We drink 16 million gallons of beer and ale and 5 million gallons of hard liquor, enough to make 26 million Americans thoroughly drunk every day. We still smoke about 85 million packs of cigarettes. We have still about 45 million cigarette smokers in the USA. I like this statement by William Collins. He says, the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas a vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog, even when 100 grams of cholesterol, now that's 200 times the average daily intake for humans in the USA, plus 120 grams of butterfat are added to its meat ration. In contrast, adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. So are we more like the rabbit or more like the dog? Well, let's look at that a little closer. Here's some characteristics of carnivores and herbivores. Now, when you look down at your appendages, do you see claws? Or do you see these hands we're supposed to be using for gathering fruits and vegetables? Now, teeth, some argue that, well, these teeth in the front of our mouth are sharp, so we're really omnivores, but most of our teeth are flat for grinding those fruits and vegetables. Now, the intestinal tract of a carnivore is short. You give your dog or cat something to eat, they got to go outside in a few minutes and do their thing. But the intestinal tract of a human being, my goodness, the small intestinal lobe's about 26 feet long. Very long, plenty of time to extract those nutrients from the fruits and the vegetables. Now, when you cool your body, do you pant like a dog or do you sweat? When you drink water, you lap it like a cat or do you sip it? Now, vitamin C, the carnivores make it themselves. Do you make your own vitamin C? Well, certainly most of us don't. And I think we're one of these carnivores, and we certainly conduct our lives as if we were. But basically, fundamentally, folks, I think we're not, as many have suggested. Now, if we could divide us in this room into 2 groups, and on this wall over here, put the pure vegetarians over several decades, and against that wall over there, put the meat eaters for a long period of time. Now, of course, most of us would walk over there. And then if we can ask a simple question, what diseases do these pure vegetarians over here not get that those meat eaters over there get? Well, a pure vegetarian, they're not bothered by atherosclerosis. Going to kill 1/2 of us in this room. They're not bothered by high blood pressure. As mentioned, we have 60 million Americans at least with blood pressures greater than 140/90. But those pure vegetarians over there, their blood pressure is about 90/60, 100/70. Certain cancers, cancer of the breast, colon, prostate gland even, are very uncommon in vegetarian societies. Diabetes mellitus, not juvenile, but diabetes beginning after about age 50, very uncommon in pure vegetarians. They're not obese, they're not bothered by peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, irritable bowel syndrome, hiatal hernia. The gastroenterologist, general surgeon be out of business if we were all pure vegetarians. They're not bothered by gallstones, kidney stones. Look at this, ladies. Osteoporosis, osteoarthritis. Can we change our health? The average total cholesterol of a pure vegetarian is about 135 or 140 milligrams per deciliter. This is a slide which was adapted from one produced by the Harvard School of Public Health. It summarizes 20 studies having to do with body weight, shown in the horizontal axis here, and our mortality ratio, shown on the vertical axis, which essentially means when we die. And what this slide shows, whether you're man or whether you're woman, the more we weigh, the sooner we die. Now we can all point out the Winston Churchills and so, but this is, for most of us, the way it works. Now this slide came from the JMA a few years ago. It has to do with cancer of the breast, death rate from cancer of the breast. Well, why is he talking about cancer of the breast? And on the horizontal axis here is the quantity of fat consumed by adults in these various societies around the planet. Well, in the U.S., we take in, according to this study, about 140 grams of fat a day. And we have one of the highest frequencies of cancer of the breast in the world. Now, this could also be cancer of the colon. The less fat a society takes in, the lower the frequency of cancer of the colon. And it could also be high blood pressure. The lower the quantity of fat taken in by a society, the lower the blood pressure. And of course, it could be atherosclerosis. The lower the quantity of fat taken in by a society, the lower the frequency of atherosclerosis. Can we change our health? Here, 2 of our 2 most common cardiovascular conditions and 2 of our 3 most common most common cancers have to do with quantity of fat consumed every day. Now this slide was adapted from a study done from data produced in World War II. As you know, 1939 to 1945, in certain countries on the planet, there was not much red meat available during that period of time, and not much butter, and not much cheese, and not much milk. And what happened to the cardiovascular death rate? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. USA, it just kept on going up. Can we change our health? Of course we can. When we pull our chair up to the table 21 times a week, we are making a major statement on our health. We're trying to decide whether we're going to control that wheel or somebody else is. Now, these are some of the little rules that I try to live by. I try not to eat between meals. Most of the things we eat between meals, if we don't eat an apple or an orange, are very high in calories, and they have a lot of salt in them. I try to make desserts and eggs a very special occasion. I avoid, what is that? I try to eat meatless meals. I'm not perfect. I still eat fish, but I don't eat the other fleshes. I try not to eat between meals, and I try not to eat anything before I go to bed at night. And I try not to eat unless I'm hungry. Now, this is the most common diet prescribed in the USA, and that is American Heart Association Phase 1. Now, what is this? This is 30% of calories from fat. Most of us, in the adults in the USA, we average about 38% of our calories from fat. And now, I reviewed charts at a local hospital a while back, 60 charts. They just started a cardiovascular program, and they wanted an outsider to review these charts. And I noted in virtually every one of these patients that when a 30% of calories from fat diet was prescribed. And as I was leaving the hospital, I saw one of the physicians that was doing this order, and I asked him, I said, what percent of calories from fat do you eat every day? Do you know how to calculate that? Well, you know, I never have done that. Well, it was ordered on every one of your charts. But I don't think many of us really know how many calories we eat every day, what percent of those calories come from fat, what percent of them come from saturated. I didn't learn any of this in medical school. When I graduated from medical school, I didn't know the caloric content of a single food. I'd walk through a cafeteria line, I had no idea, never thought about it. But I think that if we're going to change the health, we got to get used to some of these numbers. Now, if you lower a percent of calories from fat from 40% to 30%, what do we do to our total cholesterol level? How much do we lower it? What do you say, 50%?
5 or 6%.
30%? 5 or 6%? The answer is 5%. When we lower our percent of calories from fat by 25%, from 40 to 30, we lower our total cholesterol by 5%, that is from 200 to 190, and we lower our LDL by 5%. Now, some people have more effect than that, and others have no effect whatsoever. But the point is, if we're going to lower our cholesterol levels significantly by diet alone, we've got to lower them from about 40% of calories from fat to 20%. The Japanese, historically, only 10% of their calories come from fat. Now they're up to 23%. I think we've got to use these lipid-lowering drugs more. If we could all get down to 6% or 10% of our calories from fat, we wouldn't need these drugs. But there are very few of us that are going to do that. Now, there are some of us that do, and it's splendid, and that's really the pure way to go. There's no doubt about it. But particularly in people who've had atherosclerotic events, I think the first therapy should be drug, and working on the diet at the same time. In somebody who's not had an atherosclerotic event, it's diet, and then right at the end, if you can't do it that way, then you go to drugs. But in the U.S., as I understand it, only 1.5 million Americans are on lipid-lowering drugs. 1.5 million. We have at least 7 million who've had atherosclerotic coronary events. That doesn't include peripheral vascular events. So it's a bottomless pit out there. Of these various drugs, I'm sponsored here today by Merck Sharp and Dohme, but the bile acid resins, they're wonderful drugs because they're very safe, but I don't want to take them. The quantity you have to take is enormous, enormous. And I don't think they're going to have a great effect on our health. Nicotinic acid is an excellent drug. I think of it as a poor man's a statin drug. But there are too many side effects. The flushing, the itching is a major problem. Gemfibrozil has relatively modest effect on total and LDL. It is the best triglyceride lower, but in the people who you really want to get the HDL up, it's not really very effective. Probucol, unfortunately, it's virtually gone now. It's an antioxidant. It has no effect on triglycerides. It lowers HDL rather than raises them, and has only modest effect on the total and LDL. The statin drugs are safe. 20 milligrams of lovastatin per day, supper time and night, has no more side effects than placebo. These drugs have important effects on all 4 lipoproteins, and I think they should be used more rather than less. This is a coronary artery in a patient who had angioplasty. And the balloon went off here, pop that plaque, little dissection. I think that occurs in everybody. I have greater respect for the internal elastic membrane than any structure in our body. If that internal elastic membrane wasn't strong, this procedure would not be too good. But the reason I show this is to point out, even after angioplasty, a good procedure opens that lumen. The plaque is still there. And this is going to come back together again. I'm not sure lipid lowering has a lot to do with restenosis, but it certainly prevents further stenosis, or it can, in portions of the arteries not involved with angioplasty. Now here's a saphenous vein in somebody who had a bypass operation, coronary bypass. So this saphenous vein was not in the leg the last 5 years of this patient's life, but it was in the aortocoronary position. And here the lumen is filled up with atherosclerotic plaque again. As I understand it, about 25% of the people in this country who have bypass, their cholesterol levels go up that first year rather than go down. Their body weight goes up rather than go down. It's not enough just to have these procedures. We must get those cholesterol levels down. And I think everybody who's had a bypass or everybody who's had angioplasty should be on cholesterol-lowering medication. This is an important slide. It has to do with primary prevention, that is no atherosclerotic events, and secondary prevention. These patients have had an event. On the right bottom here, horizontal axis are the total cholesterol levels, and on the vertical axis, the risk of developing an atherosclerotic event. The point of showing this slide is that no matter where you start on this list, in primary prevention, if we go from 310 cholesterol to 270, we drop our chance of having an atherosclerotic event in half. If we go from 270 to 230, we drop it in half again. If we go from 230 to 190, we're at least on an average a risk. Now, secondary prevention, an event shifts this curve to the left, but nevertheless, if you start at 270 and you go to 230, you decrease the chance in half of having a subsequent event. If you go from 230 to 190, you decrease it again. So it pays big dividends to lower that level no matter where you start. I show this slide because these are coronary arteries at sites of maximal narrowing in a woman who was 103 years of age. And I show it simply to point out that we don't have to get atherosclerosis just because we get older. Atherosclerosis is not a degenerative disease. We are the degenerates, I'm afraid. I mean, look at this left main. I'll trade with her right now. That was the biggest plaque in her body, right? This left anterior center. This poor lady, 103 years old, run over by an automobile. Like Mark Twain said, the only way to keep healthy is to eat what you don't want, drink what you don't like, and do what you'd rather not. So, folks, it's up to you and it's up to me. Thank you very much. Lights on.